So what we going to have is to have submit her work. Then we'll reflect from what she's found in Mulago at the particular case. Then we can have the discussion, yes, and put it into perspective. Thank you for the guidance, Professor.
Good morning, everyone. Namakula Edith, going to present results of a study that was conducted in the hospital titled Antibiotic Prescription Trend Among Inpatients at Mulago Hospital. So briefly, before I take you through the study, we'll look at the drivers of antimicrobial resistance. And one of them is misuse and overuse of antimicrobials. We are going to see how we are doing that. We also have poor infection control, lack of rapid diagnostic tests, which we don't have for most of the antibiotics that we are using, and antimicrobial resistance to medicine, and lack of new antibiotics. So when we look at the global burden, we have 4.7 million deaths, which were associated with bacterial antimicrobial resistance, and up to 30,700 of these occurred in Uganda in 2021. So over 12,000 deaths occurred in children under 5 years, which is really, really grave. But when you look at the antibiotic prescription in Uganda, it goes up to 79%. With the compliance to Uganda clinical guidelines being only 30%. So what drove this study? We had a problem of not knowing the antibiotic prescription trends among inpatients. We also did not know the UCG compliance of antibiotic prescriptions within the hospital. And also we didn't know the bacterial resistance patterns among inpatients. So we went into a study with objectives to determine the incidence of antibiotic prescription among inpatients at the hospital. We also wanted to determine the UCG compliance of these antibiotic prescriptions, and also to determine the bacterial resistance patterns among the inpatients. So we went for our prospective cohort where we recruited 1,453 patients from the 3 directorates of the hospital. Here, this is internal medicine, surgery, and pediatrics. And we followed up these patients for 14 days while recording their prescriptions. And this was done between May and August of 2025. We also reviewed culture and sensitivity results for 1,224 patient samples, which were collected during the study. And the study was approved by Mulago Hospital REC and UNCST. So when we look at the demographics of the patients that we had, we saw that 28.7% were between 0 to 5 years, and 21.3% were between 18 to 35 years. Also 61.7% were male, and the rest were female. 51.6% of these patients were from surgery. Internal medicine had 14.1%, and the biggest contributor from the units was 18.9% from neuro ward. So when we look at the clinical characteristics and our prescription, on the first day, that is the first prescription, which we are calling day 1, we had 1,199 patients prescribed antibiotics. However, 39.6 of these were medical prophylaxis. This is the empirical prescription where there is no diagnosis which is stated, but we just have signs and symptoms, fever, and all the likes, but then we have antibiotics prescribed. Then we had a good percentage of discharge. However, we had some missing files and we also had some patients who had run away. So when we look at the antibiotic prescription per department here is directorates. That's 3: internal medicine, surgery, and pediatrics. So our internal medicine is the one you're seeing in the color here. So when you look at the first prescription, and these prescriptions were recorded at, if you wrote a prescription today, when you change the prescription, that will be the second prescription. It's not today and tomorrow until the 14 days. So every time you change a prescription, we would follow that up and see, is there any antibiotic that is prescribed? Which diagnosis was this antibiotic prescribed for? So on the first day, still you see a high percentage of around 75% for internal medicine. Second day, it shoots up to 80%. The third prescription shoots up to 85%. Fourth is 88%, and fifth is almost roughly that. So the question is, do all these patients actually have bacterial infections? Do they warrant an antibiotic to be prescribed, or we prescribe empirically? So we were so interested because we've seen that 39% medical prophylaxis or empirical prescription. So we were interested to see this empirical prescription. Let's look at the different directorates and see how are they faring. So when you look at medicine, the first one, the first antibiotic prescription, like when the patient presents, the first prescription that you write has that antibiotic. What is it prescribed for? So when you look at this, is it amber or orange? You see that 70% of antibiotic prescription is actually empirical. In other words, there's no diagnosis on the first day. That is stated, it's just signs and symptoms, and then we have the antibiotic prescription. So the rest, of course, this is pediatrics, and the other one is surgery. So what are the common antibiotics prescribed? The partner in crime is ceftriaxone, and as we are going to see the culture and sensitivity results, so the profiles, we'll see either if we need this ceftriaxone or not. So 61% is ceftriaxone, followed by the levofloxacin and metronidazole. So we see almost 61% of the patients who we prescribe an antibiotic, we prescribe ceftriaxone. So we looked also at antibiotic administration. At first, we wanted to know that, is this antibiotic administered on time? But we failed to capture that. So we went in for, is this antibiotic actually administered? We know there are so many issues to that, contributors. Sometimes maybe the antibiotic is not available, or sometimes maybe they don't have money to buy, but sometimes the antibiotic is actually available and it's not administered. So when you look at the administration per department, and again, medicine is this first one, which is like amber. So 74% of our antibiotics prescribed were actually administered for the first prescription. Now, as you go to the second prescription, it goes down to around 65%. The third prescription, roughly, it is 68%. Fourth prescription, it is roughly around 65% still, and the fifth tries to go up, maybe 68%. So that's how we are faring, whether these antibiotics we are prescribing are actually administered to these patients. So before we go for the timely administration, we have to make sure these antibiotics are administered. Then we were so interested in metronidazole because the way it showed us the picture, because it is 3 times a day administration, that's 8 hourly, we looked at metronidazole administration. Surprisingly, 3 doses daily for 1 day were only about 17%. And then 3 doses daily for 2 days were only around, I think, 24. The rest of the antibiotics. So when you look at 3 doses a day for 1 day, and that doesn't mean they switch to another antibiotic, actually, they just don't administer it. So the question is it because the antibiotic is not available, or is it because it is not just administered because it is administered 8 hourly? So when you look at 2 doses in a day, 1 dose in a day. In other words, here we are driving antimicrobial resistance, because when you give 1 dose in a day for an antibiotic which is supposed to be administered 8 hourly, you more likely not continue. So you're not doing justice to the patient. We also looked at the compliance to the UCG. The first prescription was 53%. Remember, in the studies, it was indicating 30%. So our first prescription UCG compliance was 53%. But as we go on, as the patient stays on the ward, you find that by the 5th prescription, we are at 24%. So the question is it because we are moving to more specialized medicines that are not in the Uganda clinical guidelines? And that points to us maybe developing our own treatment guidelines, at least tailor them to the UCG, but customize to the hospital. Or is it because the UCG is not accessed by most of the prescribers? So how are we driving antimicrobial resistance in the hospital? I have hinted on some of these. We misuse or overuse antibiotics. That's irrational prescription of antibiotics, especially medical prophylaxis, and also medication administration error, where we've looked at the time and duration of administration. Also medication omission, where we completely miss administering medicine because there were patients who didn't actually get any dose at all. Suboptimal access to antibiotics, which at least you can attest the hospital has tried to improve access, although we are heading there to optimal. Then non-adherence to medicine prescriptions. Sometimes medicines are prescribed, but when it reaches administration, a different antibiotic is actually administered. Then also we have the challenge of non-diagnostic informed antibiotic prescription, where we just prescribe antibiotics without any maybe CBC or culture and sensitivity. I know culture and sensitivity takes around 48 hours, but maybe we can start with CBC to at least give us a clue of whether this is a bacterial infection or not. So we also reviewed culture and sensitivity results from the lab during the study period. So this one, we've graded it in between upper and lower. And why? Because we have labs in upper different from lower. We also wanted to see, these bacteria, do they behave differently in the upper section of the hospital compared to the lower? Because we would expect them to be the same anyway. So we had some samples from blood, CSF, stool, and urine. And we had no bacterial growth for 93% of blood, and stool we had 100% no bacterial growth. When I consulted the laboratory team, I don't know if Mr. Nameta is here, but they were advising me that sometimes the machine excludes the normal flora, but still also when you look at stool and the no bacterial growth is high. So maybe the lab people will help me explain why. So is the challenge between us, from the people who collect the sample, or is it from the laboratory personnel? Because we both have to check ourselves. Or is it that the trend is supposed to be that one? So in Lower Mulago, we also have different samples. We had pus aspirate, blood, catheter tip, urine, tracheal aspirate, high vaginal swab, and others. So these patients, I think I will skip demographics. And maybe here what I can point out is the resistance mechanism. So when we look at ESBL, it is quite high, 21%, which is wanting really. And also we had some methicillin resistant stuff at 11%. We also looked, because ICU was able actually to identify that this is the unit from ICU. Most of the requests were not either indicating the unit where the request is from, or maybe it is the problem is that the lab side of capturing the unit, because both sides maybe need to check themselves. So we couldn't identify where the sample is from, so we can't tailor and say these are the common microorganisms. ICU were able to get this, and we had our Klebsiella pneumoniae and descending order as Netobacter baumannii as usual, common in ICU. So we looked at the susceptibility patterns for a few microorganisms. Escherichia coli, when you look at the profile. We looked at upper separate from lower. As I've said, we wanted to see, do they behave differently? So when you look at upper as the blue, you see that still they behave almost the same. Amikacin is the common antibiotic, which would be good. And also we have carbapenem acting well. This nitrofurantoin is coming back on the ground, actually. So we also compared the study results with the 2024 antibiogram, and still we see slightly there's no much difference. Still amikacin, carbapenems, nitrofurantoin as a culprit. So most likely antibiotics here would be nitrofurantoin. But remember now nitrofurantoin is administered 6 hourly. So, and then it also has the side effects of nausea and vomiting. So most likely the patient is not going to adhere, and it's also oral. So here you go in with IVs where we have carbapenem, but still it's 8 hours, and we've seen the problem of 8-hour administration. Most likely if it is 5 days, might not be administered all. PISA and then Moxclav would be a good candidate here since it is administered 12 hourly. And the side effects are not so grave. Also, you also have to be cognizant that if this antibiotic is stocked out within the hospital pharmacies, can this patient afford? Because most of our patients really earn around 200,000. So when you look at a course of 5 days, will this patient be able to afford? And amikacin would be very good, but then we have the side effects of phototoxicity, nephrotoxicity. So if you have kidney disease and maybe you're suspecting, you wouldn't go in for that because you'd be doing the patient a disservice. And it's also expensive in case it's stocked out from the hospital. So we went to Klebsiella pneumoniae, still upper and lower. We saw amikacin being very good. We also saw carbapenems trying, and we also looked at nitrofurantoin. When we compare 2024 and the study of 2025, more or less the same picture. There isn't much difference. Carbapenems, amikacin, nitrofurantoin. So most likely here we have 3 options: nitrofurantoin, oral, but 6-hourly administration. Carbapenems, 8-hourly administration. You have to follow up to ensure it's administered. And amikacin, but remember the side effects and also how cheap it is to the patient. Staphylococcus aureus, this one has very many options. Amikacin, we have carbapenems, are also not so bad. Linezolid, we usually reserve it for the TB likes, but we also have levofloxacin trying. So when we compare 2024 and the study results, more or less the same. We bring in the picture of some, as we're doing this, by the way, look at ceftriaxone, because whichever antibacterial I'm looking at, you look at ceftriaxone, either it is 0 or below even 30%. But remember, it's our common antibiotic prescribed. So here we have a number of options. Nitrofurantoin, oral, clindamycin, levo, but remember for the bone issues. And then amikacin, the side effect. Linezolid, reserve, and vancomycin. But of course, if the patient is critical and that's the only option, you weigh benefit outweighs the risk. Acinetobacter baumannii, our enemy in crime, we see the only option here we have is amikacin. Meropenem, carbapenem is not so good though, because we see it is roughly at almost imipenem is the one which is trying, but still less than 50%. So we also compared 2024 and the study of 2025, still the same picture. Only good candidate is amikacin. Meropenem tries, but not so good. So here we have 2 options, the carbapenem and amikacin. And amikacin, very good, moderate susceptibility, but side effects. Also, when you look at meropenem, low susceptibility, and it is 8-hourly also, meaning you have to really beat up zone for the people who are administering to really administer it on time. Citrobacter friendly, this one also amikacin is good, nitrofurantoin, but remember it's oral, and also PISA. Most likely antibiotics here would be nitrofurantoin, meropenem, PISA, and amikacin. Pseudomonas aeruginosa, still we have amikacin, Gentamicin is coming back, but remember it was recalled because of ototoxicity, so you have to be cognizant of that. Benefit outweighs the risk. And piperacin, tazobactam. Most likely antibiotics, we have our carbapenem, we have our pisa, amikacin, and gentamicin. So when we looked at all that, we had some cases of multi-drug resistant microorganisms where we had no antibiotic action susceptible, which the microorganism was susceptible to. So Klebsiella pneumoniae, 15% of the patients who had that bug had MDR. Pseudomonas aeruginosa, 29%. Acinetobacter, 50%, meaning if you get Acinetobacter, the likely chance is 50% of these patients are not going to have any antibiotic that you can use for treatment. So here I have the antibiogram for 2025. As we've seen, we had ceftriaxone mostly prescribed. But when you look at our ceftriaxone, I don't know if you smell that to do what I want. CRO is our ceftriaxone. So when you look at CRO, look at Klebsiella pneumoniae. Klebsiella is 11%. So 11% of bugs or the microorganisms will be susceptible to ceftriaxone. When you look at Escherichia coli, it is 14%. When you look at Citrobacter friendly, it is 24%. So even the other antibiotics, and what I noticed in internal medicine, I think the P drug there is ceftriaxone. Most of the prescriptions we looked at, we had a lot of epicephin being prescribed. Sometimes they would switch to some ampicillin, but most of the patients are prescribed ceftriaxone. So when you look at our carbapenems there, imipenem and meropenem, IMP is imipenem, then we have our nitrofurantoin as well. You look at the susceptibility of the different microorganisms. When you look at stuff, if that is what you're suspecting, what can you prescribe? So that was the 2024 antibiogram. And when you look at the 2025, the picture is more or less the same. There isn't much difference. Still, when you look at the ceftriaxone, you see more or less the same picture. There are incidences like where you have zero susceptibility for E. coli. And you wonder if I prescribe this antibiotic. So for Klebsiella pneumoniae, we have 25%, 10% for E. coli, 0 for Acinetobacter. As we've seen, all those graphs where you are seeing 0 and there's an antibiotic means it has 0 susceptibility. Then we look at Proteus, Probacter, Staph aureus. So most of these antibiotics actually, as much as we go in for them, at the back of our mind, we should know that which microorganism am I suspecting before I prescribe this antibiotic. So we recommend approving annual antibiogram review, also supporting antimicrobial stewardship activities. Now this one goes to Medicines and Therapeutics Committee. Let them align antibiotic procurement with susceptibility data. In other words, let this feed into their procurement planning. Then also infection prevention and control measures have to be streamlined because sometimes we use like one glove for all the patients. And also we had some cases in internal medicine, I don't remember which unit, but the patient passed on and then there was no IPC done properly. So they just locked the room, then the next patient admitted and actually on that bed where there was no proper IPC done. And then this patient had passed on, had an MDR microorganism. So we are wondering now, aren't we doing hospital-acquired infection? And then also we need to adhere to culture and sensitivity testing before antibiotic prescription. Yes, this takes like 48 hours to get the first result or sometimes 24, but at least we start with a CBC to be indicative of what we are treating. Also, we need to improve timely antibiotic administration to inpatients. Establish a system to track MDR cases. And this goes to the prescribers as well. If we are to do this, then we need maybe you indicate your phone number such that if we get that MDR case, we are able to alert you on time. Also, we need to develop department-based treatment guidelines using susceptibility data. Now that are we going to still prescribe ceftriaxone, ampicillin, and the likes, we need to have our own customized treatment guideline. We acknowledge the Mulago Hospital staff, the committee members, and the hospital administration for funding the study. Thank you.
Thank you so much, Dr. Edith. We can now pause it here. She's been generous to share with us the antimicrobial susceptibility pattern, some copies here, the ones who are having difficulty to view in the images. I could have said let the panelists take the seats, but the seats are probably less than the panelists. So we have the residents from ID Ward and Dr. Edith. So we can now pause it and have some comments or questions to reflect from the case to the perspective of the study revelation that Dr. Edith has shared. Can I say, unfortunately, I do not have portable microphones this morning, but we'll relay some of these questions for the online team, but I presume that we can have enough. Yes, Isaac. Question goes to the case panelist or the study panelist? Okay. You, that's the question. Yes, Professor.
That's why at the end I said this information has to feed into Medicines and Therapeutics Committee. I already relayed this information to them about ceftriaxone, metronidazole, carbapenems to try to streamline the procurement plan. Because sometimes they come back negative. Maybe this one, the lab team will answer, because I thought when they give you the profile, that is the susceptibility of the bugs that they are suspecting. That's the that have grown. And also, yes, availability, as I said, we are going to air it out with the Medicines and Therapeutics Committee. Then also polymicrobial infections. How do we handle? Yes, in this study, we had some cases where we had Acinetobacter with some other bugs. So most of the time they do that profile with all those bugs in mind, and they give you the profile of both. So you'd look at the antibiotic, which is cross-cutting for both of the bugs that you're having, and that is the one you prescribe. Ceftriaxone bioavailability is 10%. When you look at our procurement these days, we stress epicephin. Personally, I told the procurement team, I don't want you to procure brands which are not good. So we bring in epicephin, but still, when you look at the profile, still susceptibility is very poor. So epicephin is a good brand. So we assume the active pharmaceutical ingredient up to 100%. So if it is resisting, that means the bug is actually resistant to that. The challenge is in the community, before the patients come to the hospital, they've used now poor brands. So even if you give a good brand, the microorganism is already resistant. Do we assume in vitro versus in vivo resistance? I'm going to forward this question to Dr. Phoebe to answer. And then also past prescription, what was it? Now this prescription, we didn't look at what they prescribed at emergency. We looked at the unit, what you prescribed first as a unit. Because most of the time at emergency, they take less than 24 hours. And then they refer the patient or transfer the patient to your unit. So this prescription is for the units where the patient is. Gram positives, how do we handle? I'm going to forward it to Dr. Phoebe to help me answer that. Thank you.
Thank you so much, IDWOT panelists and Dr. Edith. I know that we pressed with time, but allow me just let you put the rest of the comments or questions in the parking lot and give about 3 minutes for the short talk from Dr. Sauda Namubiru. She's an expert clinical microbiologist from the Central Public Health Laboratories, and she's our guest today. She's accepted to come and give us this perspective. So I think that should also lean into some of the comments in the chat room, that what are the next steps or which directions do we take? I think I implore us to reflect on the recommendations that Dr. Edith has shared. What's our practice? Is it the right drug? Is it the right diagnosis, right route? What is the frequency? But also such studies help us know which of the common bugs are we likely to face and how to de-escalate antibiotics. Dr. Sauda, you're welcome to the podium to share with us.
Very good morning to everyone. I'm being told I have 3 minutes. Let me try and marathon. So just very similar to what we've been discussing, it is antimicrobial diagnostic stewardship in clinical care. What is the role of rapid diagnostic platforms like the BioFire film array or the multiplex PCR? Okay, so I just leave that quotable quote that is probably old, but you can replace penicillin with ceftriaxone. and say that the thoughtless person playing with penicillin treatment is morally responsible for the death of man who succumbs to an infection to a penicillin-resistant organism. So as a matter of outline, that is what we are going to discuss. So the question is, what is antimicrobial stewardship? And it is a coordinated approach to reduce resistance, encourage appropriate use of antimicrobial agents. So I talk about the right agent, the right dose, the right time, and right duration. And of course, this is pretty boring, knowing that we all know this. So the ultimate goal of antimicrobial stewardship is to achieve the best possible outcomes. But then where does antimicrobial stewardship fall in the diagnostic pathway? So you're saying you receive a patient with symptoms, you perform history and physical examination before ordering any tests. And of course, my teachers here will agree that you get about 85% of your diagnosis. So by the time you're getting your pen to request for a test, you have a pre-test disease probability that I think this person has pneumonia in view of ABCD. And then you're even suspecting that given maybe this is an immunosuppressed person, this is probably a fungal pneumonia, or it is bacterial, or it is tuberculosis. If your pretest probability is not yet fully 100%, so you're 50-50, then you order for a test so that the laboratory or whatever diagnostic platform can help you confirm. But if you're sure, then you don't need the laboratory. If you're sure it is not infectious, then you don't need to order for a test. So when you get that, and the whole point is to order for the right test, not to just send blindly to the lab and then you say, okay, tell me what else, whatever is in here. And then of course, when you get the results, you weigh. Do I need to treat this patient, or is it an organism that can clear on its own? So then that is where the diagnostic stewardship comes in, which is coordinated guidance and interventions to improve appropriate use of microbial diagnostics to guide therapeutic decisions. And by appropriate use, we do not mean that you use cost-effectively the laboratory services, although it is part of it, but it is getting the best possible diagnostic platform that will help the patient. So what is the relationship then between diagnostic stewardship and antimicrobial stewardship? And I'll just say they are intimate cousins, but at the center there we have a healthcare provider who is all of us in this room. So the patient is out there, the lab is down here. So you're having a right test for the right patient at the right time to give you the right interpretation and the right antimicrobial. So why is diagnostic stewardship then important? We have seen that there was a study in 2019. Of course, this was largely in children, where 1 out of every 2 children received an antibiotic, and often it was unnecessary. And because of their vulnerability, the immature immune system, and the dosing challenges, and microbial exposure also has those unique long-term risks, like the microbiome disruption, which is linked to allergies, the asthma, obesity, toxicity, to mention but a few. So we said that effective antimicrobial stewardship should be multidisciplinary. It is not just about the doctor, the nurses involved, the pharmacist, and even the patient themselves. Then it integrates diagnostic stewardship within it, and all clinicians or the clinical team and the caregiver is very important. And it requires context-specific strategies, because every patient comes with a unique presentation. So this is the Mulago Hospital data at a snapshot. This is the 2025 data. And we just looked at, out of the 5,821 samples or specimens, we had 63% that had no growth. By no growth, we mean no significant growth. And then we had 37%, which is a moderate yield. So the question will be, are we over-testing? Are we sampling late? Are we sampling at the wrong time? Or are we sampling post-antibiotic exposure? And then when we look at the top pathogens, we have E. coli, which is predominantly from urine. And you know that E. coli has been taken as our indicator pathogens for urinary tract infections, both community and the complicated. And then we had a lot of Candida albicans, and most of this was even from urine, which is likely a colonization as opposed to a true pathogen. Then we had Staph aureus, which was about 19%, which was responsible for the surgical site or soft tissue infections and invasive infections. But of course, other infections like Citrobacter, Klebsiella, which have an implication of nosocomial capability, were also seen. So what are the critical stewardship flags? We had a high. So this risks overuse of antifungals if we do not interpret it with the right context. Then we had mixed growth and contamination, which could suggest poor specimen quality. And then we had the high negative culture, which could be either late sampling or overuse of antibiotics. Then what are the AMS opportunities in this? We should stop treating asymptomatic candiduria or any other likely colonization as opposed to true pathogens, improve blood culture interpretation or generally culture interpretation, enforce specimen quality protocols. And this one, we are talking about having champions for collecting of diagnostic specimen for culture, promote de-escalation when necessary, and then most importantly, strengthen the laboratory clinician communication or interface. So the current challenges in infectious disease diagnosis, of course, there are non-specific symptoms, especially in children, which sometimes really confuse whether this is infectious or not. We have difficulty differentiating viral from bacterial infection just by clinical examination. Then we have the high diagnostic uncertainty, and that is what leads us many times to the empirical antibiotic use. And then, of course, we have the delayed turnaround time. Unfortunately, the bacteria have a lifespan or a life cycle that we cannot rush with the current culture methods. And then, of course, we have the fragmented testing. If I'm going to order for culture and that is for bacterial, and then I have to do maybe a viral PCR or something like that, it becomes really a challenge. Then limited sensitivity, poor specimen quality, and then taking off samples after antibiotic initiation. This is a referral hospital, and then, of course, contamination. So, okay. So anyway, we are requesting that, I'm requesting for at least 3 minutes to try and wrap up. So we have the traditional versus the syndromic testing, which is now the BioFire. And as you can see, the traditional methods take a really long time as opposed to some of these multiplex or molecular methods. So one of the game changers that we have seen recently are the rapid diagnostics like the BioFire. Currently, we have about 7 panels. We have the respiratory, which really looks at the upper respiratory tract. We have pneumonia, blood culture, meningitis, joint, GI, and then the tropical fever panel. Sorry. And the whole beauty is the BioFire has an ability. By the way, I'm not a representative of BioFire. I have to declare no conflict of interest. So it's a rapid detection of multiple pathogens within 1 to 2 hours with simultaneous identification of different pathogens, but also their resistance markers. And it enables timely detection. But most importantly, it is free for very sick and deserving patients where the diagnosis really contributes to the care. So quickly, the blood culture panel has all those targets, including the genes. The GI panel, I'm sorry, I can't let people take pictures because I'm rushing. Yes, I'll share the presentation. The GI panel has the common organisms, the respiratory, well, just a few use case scenarios. We had a 12-year-old male with 7-day history of fever, cough, and difficulty in breathing, was being treated for bacterial pneumonia with IV ceftriaxone and gentamicin with minimal relief, was a P7 candidate, was readmitted after collapsing, was now prescribed meropenem, but luckily they ordered a BioFire, and what we got was coronavirus, which is the non-COVID-19. So they stopped all antibiotics, and the patient had, of course, very meticulous management of the fever, and after 2 days, the boy was well and running. The second was a 9-day female preterm neonate with neonatal sepsis being treated for bacterial sepsis with IV cefotaxime and amikacin. Baby was getting worse. When we did a BioFire, we saw Klebsiella pneumoniae with that CTXM gene, which of course shows there's already resistance to the ESBLs. So we changed and we gave a carbapenem. We stopped the amikacin because of the potential toxicity. And when we did the culture and gram, we saw that it was in agreement and the baby was able to be saved. Another was again some neonates. These ones were having suspected meningitis. The biofire showed us Kleb pneumoniae with NDM and CTXM. Of course, these are carbapenemases, and the culture results confirmed. So for the baby who received the biofire and the quick diagnostic interpretation, was adjusted to ciprofloxacin and he survived. Unfortunately, the second twin didn't make it because they did not order for biofire. We don't know what bug they had and what susceptibility profile. So we encourage that. We know the medicine department has been using biofire. Please share your experiences with us so that we can see how to make it better. But the lessons is the test is demanded and more of these are demanded, but some panels are underutilized, especially the joint and some of the meningitis panel. And then, of course, we lack standardization in request forms. We have that standard microbiology request form, but this may not be available. Both private and government are embracing it. Remember, it is free of charge for deserving patients, but we see that clinician engagement is very critical. Innovations like CMEs like these are very important. And then we do not use the biofire in isolation, but rather as part of the full microbiology workup, where culture and sensitivity remains the gold standard. The test is still very expensive and we are getting justification for investment, but we need more panels to cover more questions like the torches and some parasitic. This is just something about the condition reporting for the genes. We do not, because the biofire looks at the DNA, we do not use it in isolation. We use it together with the clinical picture, and the genes have to be in line with the organism that is detected. So the take home is stewardship is driven by better diagnosis, that is clinical and laboratory, not just laboratory to identify the clinical. And then we need better result interpretation in line with the clinical context. So we encourage that every time you send a sample to the lab, please back it with a detailed clinical history, because some organisms are pathogenic in particular conditions, but are not in others. And then, of course, better decisions, faster decisions, and smarter antibiotic use. So in clinical care, the biggest gain is not in antimicrobial stewardship, may not come from new drugs because the pipeline is narrowing every day, but it may come from the faster and smarter diagnostics where the clinician contributes highly. And that is where the ministry gets its slogan from, or the campaign from, that my clinician or my prescriber is my AMR champion. So we acknowledge you all and thank you so much. I hope I've marathoned well enough.
Thank you, Dr. Sauda. Another round of applause for the ID team and the perspectives to learn about the microbiology of our setting. I know we're 10 minutes or so late onto our time. I'll quickly invite Dr. Mbabazi, one of the lead physicians, to help us organize this talk and be very educative, to give us the comments and remarks, and then we'll invite the mini round patron, who will then, by protocol, invite the head of department to close our discussion this morning.
Good morning, everyone. Would like to thank the IB team for, I think it was a great presentation, and Dr. Edith and Dr. Sauda as well. For me, the take home from today is one from the AMS study. One, we are prescribing antibiotics with unclear indication. So we need to rethink that history taking, physical exam, and decide, do we need the antibiotic? And then, of course, our choice of antibiotics. So, of course, this goes to the AMS committee and the medicines and therapeutic committee about rethinking which antibiotics we are procuring for the hospital. And then, of course, administration of drugs. At the moment, we are using a lot of PISA, which is 8 hourly for patients whom we think have resistant organisms. But a lot of these patients are getting 1 dose of PISA. So we don't know what is going to happen in the future. So we asked Dr. Sauda to talk about the BioFire because it is available. But I think the key thing is that it's available for critically ill patients, patients where we really need the result. And usually you get the sample. So she has mentioned we have CSF panels. We've had that CSF BioFire on the ID ward where we got HHV6, which we probably would never have thought of. We've got Clostridium difficile. We've got some stool biofires with norovirus. So it's available and we encourage you to use it where you think it's going to make a change in the treatment of the patient. So either blood, GI, she mentioned the panels, please request for it. So the sample is usually taken to the microbiology lab. There is a hub system where the sample is able to be taken to CPHL for testing. Thank you.
Thank you so much. Invite our mini round patron to give us some remarks. Just quickly to reflect that we've done a round now. We're coming back again towards for our mini rounds, and that's a signal that usually the semester is closing. We're meeting next week for a legacy round for pulmonology. It will be a triple involvement. We'll share that on email. My name is Jumbo Moses, your mini round coordinator. I invite Dr. Sanita Radamina, patron.
Thank you, Dr. Samitala. Good morning, everyone. So very quickly, I think there's data from the World Bank suggesting that the GDP losses by 2030 from antimicrobial resistance are $1 to $3.4 trillion. Sometimes the language, and the point I'm making, sometimes the language that policymakers understand has to do with cost. So maybe for Dr. Edith, it would have been interesting for you to integrate a cost component to that study. How much money is being lost, right? From you say you're going to give 3 doses per day, but you give 1, but then the patient gets resistance and they die. I know sometimes it can be a bit of complicated, disability adjusted life years analysis. But that's the language that I think telling people that 10 people died sometimes, because we are just so used to seeing death. It might not, they may just say, sorry. But if we come down to this is how much it's costing you. The signal for ceftriaxone resistance, it's almost 6 years now. Dr. Kajumbula can bring data from here from 6, 7 years ago that showed the ceftriaxone resistance climbing, But we are still our favorite antibiotic. Anyway, so I think those are things that we need to think through. Put a cost to this thing so that people understand. I don't think people like organizations like the World Bank go to the extent of posting things just for the sake of headlines. But sometimes that's what brings it home. When you understand how much money you're wasting or what it's costing you. And you might find the cost of, if you just install some fire machines here, it will actually just mitigate that loss. So those are things I think that we need to think through. Ideology. Where is Rita? What happened? We're supposed to have a cardiology ground round this afternoon. Do we or do we not have one? But so are you going to so what is the plan? That's how. No, I think this goes back to timely communication. Huh? If somebody tells you there's a mini round 2 weeks from now, and cardiology, I mean, at the beginning of the semester, there was a schedule. It's just don't allow people to wait until a week before, a month before start having the conversation. Okay. They are always patients. Can't say they are not patient. So we are killing the learning if we don't have this session. Okay. But let's not just think about us, but who else attends these sessions, whether that's online or. So let's be organized for future. 3 weeks to go. I hope people are getting ready for exams, but I keep telling students it's not about the exams. That patient down the road is not going to ask, what was your score in internal exam? They are going to wonder just from your interaction with them and whether you treated them and they went home. So learn the skills. That's even more important than scoring. Score well, obviously, in order to go away. Okay, thank you very much. And let's come back next Tuesday. I don't know, you said the triple something, but enjoy the rest of your